All right, this is the February 2026 MEC Minute, and our topic this month is avoiding medication errors. This is a topic that we've discussed in the past, but recently we've had a kind of an uptick in the number of medication errors for while providing care for our patients. And we've gone through a period where we really didn't have many, if any, medication errors, and recently we've had more than half a dozen. And what's concerning is not just all of a sudden we're having these errors, but the errors are being made by experienced providers who know the process and have been through this training in the past. So it's time for an update and a refresher. So what are we going to talk about is we're going to review some of the reasons for medication errors, particularly why do errors happen in the pre-hospital arena. We're going to talk about our procedures that you can use to avoid medication errors, and then also discuss our cross-check procedure. So we'll go through all of this, and I know for some of you that my discussion and focus on the cross-check procedure is not new. Please take a look at it and beware of it. And when we're finished with this conversation, please go back to the protocol, look at it, make sure you have a good understanding of it. So just to start with a fictional case, this is just a fictional case. It's not a real person. EMS is on scene, a behavioral emergency. A crew has completed an assessment, which is great. They determined the patient's got an SAT of +3. During the course of their assessment, they were able to get an IV started. The crew estimates the patient weighs 100 milligrams. The in-charge medic asks her partner to draw up 200 milligrams of ketamine. The ketamine is administered, and 90 seconds later, the patient becomes apneic. The patient is appropriately resuscitated and then transported to the emergency department. For the sake of this conversation, let's assume the patient does fine. But if we had this adverse event happen, what went wrong? So what could have possibly caused this? One is there's no errors by EMS. There was no potential complication of sedation and respiratory arrest. This patient just happened to have it. But we really shouldn't accept that as the automatic excuse or reason. It could be that we didn't weigh the patient right or made an incorrect assumption on the patient's weight. Maybe the patient was actually 75 kilos instead of 100. The 2 milligrams per kilo was appropriate for an SAT of +3, but maybe the patient was just lighter than usual. Or maybe there was an incorrect dosing calculation. Somebody drew up more medication than should have been given. In other words, they thought they were drawing up 200 milligrams, but drew up 300 milligrams. Another possibility is maybe they grabbed the wrong concentration of medication, and instead of using the concentration, the 50 milligrams per ml of ketamine, they grabbed the ketamine intended for intramuscular injection, and the patient got basically twice as much medication because the wrong concentration was used. Or it could have been that the incorrect medication was administered. In other words, the partner, instead of drawing up ketamine, drew up a paralytic. So all these things are possible, and we'll talk more about this after our conversation, and I go through the other materials. But just think about it as we go. So what is the scope of this problem? And really, as I was surprised as I started to do some investigation to put this discussion together, but there's been several articles published over the years, and there's an estimate about 30% of EMS medication administration involve at least one error. Pediatrics have a higher error rate because children are smaller and we don't always have an accurate weight. We may have to use a Broslow tape or some other means of determining the medication dose. And the tape and these other tools are good, but they're not perfect. Some kids are lighter or way less than the tape would suggest, or way more based on what their BMI is and whether they're thin or average or overweight. And a lot of times these errors that are counted are incorrect dosing amounts, where the patient is being over or underdosed. And it's often underdosing, meaning the protocol says the patient should get 75 micrograms of fentanyl, but instead of giving 75, the crew elects to give the patient less. That might be considered an underdosing of medication and a medication error. The studies also show out there that the medication cross-check procedure that we use, which we are mirroring from Kansas, can reduce errors by 50 to 60%. Some people refer to it as about a two-thirds reduction in errors if you follow the cross-check procedure that we have in our protocol. Just as a side comment, when I look at medications and review, I would agree that we often underdose our patients, particularly when it comes to pain medications such as fentanyl. We tend to go a little light on that. I really don't have a problem with that because if you do it intentionally, you can always give more medication if the patient needs it. So sometimes the correct thing to do is to underdose a little bit and give more medication if it's indicated. So just a comment about never events. So never events are serious, identifiable, and adverse events that should not happen. They're generally seen as system failures. Never events, examples are a patient has surgery and a hemostat is left inside the abdomen. They close the abdomen and then later find the hemostat and they have to go in and take it out. Or the patient has joint replacement surgery of the knee, but it's done on the wrong knee. Those would be considered never events, and they are considered system failures. There was not a correct instrument count during the surgical case, or nobody verified with the patient that the surgery is going to be on the right knee and not the left knee. But medication errors are also considered never events. We really should not accept them as just something that comes with the job. They are generally preventable, and we should not accept them as something that just happens. So any medication misadventure, particularly anything that results in potential harm to the patient, should not be accepted as just something that happened. We should see that as a never event. We should investigate and identify opportunities to avoid it in the future. Particularly when one of our most common causes for us in medication errors is using the wrong concentration of medication, which has been the most common reason we have problems with MEC for medication errors. We should consider those to be never events, and we should investigate and find ways to remind the provider that they're using the correct or incorrect concentration of that medication for the patient. So we should consider medication events or medication errors as never events, just like we should never find it to be acceptable that a firefighter is hurt on the fireground or dies on the fireground. Those should all be investigated. We consider those to be never events as well. So really, if you look at medication errors, there's kind of 7 types that have been identified. The first one is like organizational error, and that's principally something like a protocol error. So if we have an error in the protocol and our provider follows the protocol and there's a medication error because the protocol identified the wrong medication or the wrong dose, that would be considered organizational. That comes back on all of us to go back and look at the protocol and make changes. Sometimes there are equipment problems. There could be a malfunction or design flaw. It could be related to how the medication is stored. It could be related to having incorrect syringes or syringes that don't measure to small enough volumes. It could be we use a 5 cc syringe draw of a medication where you really should have a 1 or a 3 cc syringe. I think the biggest problem we have with it from an equipment perspective is we go for the red colored cap when the medication no longer has a red colored cap. What's wrong about how we do that? There's the environmental cause of medication errors. This is one we are always fighting. We're in poor lighting conditions. We have distractions. We're in a high stress situation, and there are opportunities to make mistakes. If you can't read the vial well because there's poor lighting, that's an opportunity for an error. There are also procedural errors where we don't follow the cross-check procedure. We don't follow the 5 rights of safe medication administration. So sometimes, if we follow the process, we will be better off. Sometimes there's misunderstanding between providers. Provider can think you asked for one thing and they give you something else. So we need to have that back and forth conversation where you identify what you want and the other provider verifies or repeats what you're asking for. Very similar to what you might do as part of radio communication with dispatch or scene command. Sometimes there are patient-related problems that we're not aware of. We may administer a medication and the patient has an allergy to it. We try to avoid that, but sometimes patients aren't aware of what their allergies are, or it could be a newly identified allergy based on what we give the patient, or it could be the patient's just not able to tell us that they have an allergy. And then sometimes there are cognitive errors. We make mistakes. There's lapses in judgment. We do something hoping for the best when it doesn't go that way. So sometimes, we may not have the information we need. I would suggest that if you want to avoid some of these cognitive errors, look at your protocol, see what the correct medication is. If it's a medication you don't use commonly, make sure you identify the correct dose for the correct reason and use the correct concentration based on what's in the protocol. So we do have some opportunities to avoid these cognitive errors. What other things contribute to these medication errors? Situations can make errors more likely. So a disorganized workflow, disorganized workplace, interruptions and distractions, time pressures, situations of high stress. I mean, all four of these things can happen on a bad scene. This is something we deal with on our runs frequently. So just the situation itself can make it more likely that we make errors. And we've had a couple of errors recently where the errors were made because the providers were in a very stressful situation and they were just overwhelmed by the stress and the circumstance. Sometimes lack of written orders can lead to errors as well. If somebody asks you to do something or you get a verbal order to provide certain care, that's a situation for errors. When I was practicing in the emergency department, I rarely gave a verbal order to the nursing staff. I usually went to the computer and put it in so that it was communicated, clearly written, and we didn't have to worry about me clearly articulating verbally to the nurse what I wanted done. So that is a frequent source of errors, more so in the hospital. But I think you could also use this as a reflection on, making assumptions and not looking at the protocol when it's available. Sometimes errors are related to incorrect units of measure. Is it milliliters versus milligrams, pounds versus kilograms? Are you basing your dose on patient's weight? All of our medication dosing is based on kilograms. But if mom says the child weighs 25 pounds, did you take that as 25 pounds and make a conversion to kilos? Or did you take that directly as kilos and make a calculation on 25 kilos when the child actually weighed about half of that? So that's an issue. Or milliliters versus milligrams. I've got a graphic I'll show you in a minute, but it could be the dose is based on milligrams, but you have a certain concentration and you have to calculate how much volume is going to give you the number of milligrams of medication. So you have to be very careful there. High-risk medications are a source of errors, and for us, that is differing concentrations. We have two medications, midazolam and ketamine, comes in two different concentrations each. The more concentrated is meant for IM or intramuscular injection. The lesser concentrated is meant for IV. The wrong bottle can be grabbed, and the wrong dose can be given to patients. Sometimes we have errors made due to medication substitution. So let's say we run out of ketamine, and now we're going to go to droperidol for behavioral emergencies. Different medication, different concentration, different dosing schedules. If you're not used to using droperidol, you really probably should be trusting your memory. Go look it up and make sure you make the correct administration. If you don't do that, you could have problems. And the last thing that I can really contribute to medication errors is lack of a non-punitive process to report errors. In other words, lack of a culture of safety. And I like to think that really for us, we support having a non-punitive, non-disciplinary process to report errors. For me, errors are an opportunity for training, an opportunity to look at our process. Like I mentioned earlier, under never events are thought to be a system issue. They tend not to be a person issue. I don't think our providers intentionally go out and grab the wrong vial of medication. They grab the wrong vial because there is a procedural problem in place. So I think we need to support having a culture of safety input, and self-reporting is important so we can go back and do a root cause analysis and find out why there is an error and how we can avoid errors. Just kind of our dancing medications here. These are the meds I talked about. Which one is ketamine you're going to give IM versus IV? If you're looking for the red-topped vial, well, it may now be an orange-top vial. You have to look at it. You have to look at the labels, and you have to look how it reads. So if you look at the two ketamine vials on the right, both of them say 500 milligrams, but one is 500 milligrams per 10 ml, which is the more dilute. The one on the right is 500 milligrams for 5 mLs, which is the more concentrated. So it would be very easy to take a quick look at this and make a mistake. Same thing with midazolam on the left-hand side. So these concentrations for me are the problem medications. We need to have them on the truck, but your agency needs to have a way of identifying high-risk medications. So something to prompt you to think, whether it's a label or you put them in a special spot in the medication bag, or you put the one concentration in a red pouch that makes you want to say, oh, I better pay more attention to what I've got. I found this graphic illustration. Just looks at all the different ways you can make mistakes in calculating the doses of medications. This is particularly important in children, where you're going to do a dose per kilo, a dose per weight. If you look on the left-hand side, it says weight-based dose ratio. It talks about two different dosing schedules based on whether it's IV or IM. Or whether, in the case of ketamine, it's for analgesia versus intubation. So you have to know exactly what you're doing. At top center, it talks about patient weights. Again, is the weight correct? Have you got a weight on the patient that's in pounds, and now you have to convert to kilos? Do you have to take pounds, divide it by 2.2 to get kilos? And then, you have to then take all of that and look at the medication concentration, which is on the bottom. And then you have to do math to come up to how many milliliters of medication are you going to administer. Some things we can do quickly in our head. Some things take more time. Sometimes you have to make adjustments in which how you calculate it because of the concentration of the medication. So it can be difficult. We understand that. So what happens if an error is made in medication calculations, medication administration? Well, the base case scenario, there's an error made, there's no harm to the patient, and there's no change in patient outcome. Patient is having pain, they get a little more fentanyl than they should be getting based on our formula, but the patient's pain is controlled. They stay awake. Their capnography and their pulse oximetry is normal. No problem. Patient gets the medication. They get more than they should. Let's say they get they get more midazolam than they should based on their weight. For a behavioral SAT of +1, they get a little bit more than they should, but they're sleepier than you'd expect them, but they wake up and they do fine. Again, there's error made, but no harm. But there's second possibility is errors made and there's some harm to the patient. And that harm can come in varying degrees. It can be something minor or inconvenient to something that results in long-term disability. So this middle category is very broad. The patient who had the wrong knee operated on, that's a big event, and it may or may not be impairing or result in long-term impairment to the patient. He's still going to have to go back and get the right knee operated on at some point. So that's still a big issue. And then finally, there's an error made and the patient dies as a consequence. These we want to avoid. I'm not aware of that happening for us, any of our patients. We don't want this to happen. We don't want to have that conversation, but that's the ultimate bad outcome is we administer the wrong medication or incorrect amount of the medication and the patient dies as a consequence. You often hear about the five rights of medication, which we can use as part of our process to do things safely. We want to use the right drug for the right patient. Well, we do one patient at a time, so we should have the right patient there in the truck. We want to use the right medication. So the patient is having pain, we want to pick a pain medication. The patient is having a seizure, we want to pick the right medication. We want to find the right dose, and we want to provide it via the right route. Now, you might want to determine the route before the dose, particularly if there's concentration issues. So if you're going to give an IM dose of midazolam for seizure, we want to give the correct amount of midazolam, or the right dose, which for an adult would be 10 milligrams. And we want to give it at the right time. The patient's still seizing, he needs the midazolam now, or the patient's not seizing, he's post-ictal, we don't need to give the midazolam now. There have been some critics about the five rights of medication, in that really is these five rights, using the five rights has not been validated as actually reducing medication errors. And it's really frequently taught as a one-person action. So it's what a nurse will do before administering the medication, rather than the nurse doing cross-checks with a coworker. And then really five rights are seen as by some as reflecting the goals of safe medication administration, and really do not reflect the amount of mental work and the thought and the complexity of safely administering medications, or the context of medications, such as you're back in the truck in a truck with an unstable patient, and now they're having a seizure, and you need to get a dose of midazolam in them. There's nothing wrong with the five rights. There's nothing wrong with using them, but there's suggestion made that there's more that needs to be done than just the five rights. I thought this would be a good time to talk about how do we keep people safe in the hospital versus in the ambulance. If you're at the hospital these days, with the electronic medical records, there is a strong prejudice against verbal orders, and generally verbal orders are only given in life-threatening situations. But generally, the provider, the physician, the nurse practitioner, the PA goes to the computer, puts a medication order in. That medication order is then validated or signed off by the provider with their fingerprint. And that order is verified by a pharmacist to make sure that it's a correct order and the medication is appropriately dosed. Once the pharmacist signs off on the order, the nurse can then pull the medication from Pyxis. When the nurse goes to Pyxis, they have to identify the patient. They have to identify the medications that are coming up for the patient. And when they push the buttons on Pyxis, the device will only allow them to take out the medication that's been ordered by the physician and approved by the pharmacist. The nurse will then take the medication. They walk to the patient's bedside. They have a barcode scanner on the bedside computer. They scan the barcode on the medication. They scan the barcode on the patient's ID that they're wearing on their arm. That will then reconcile and validate that the patient has the correct medication for the correct patient. It's not that she took the correct medication out of the computer and went to the wrong patient. So it's been valid. It verifies the patient. She's got the right medicine with the right patient, and then the medication is administered. So very, very complex process compared to what we do in the field, but it keeps the patient safe, and it's done a lot to reduce medication errors. How about for us? Well, the provider, EMS provider, refers to the protocol or knows what the protocol is. They take the medication out of the drug kit. The drug kit is wide open. They can grab the wrong medication if they're not paying attention, especially if it's not in the drug safe. We should, based on our protocol, then provide a two-provider medication cross-check, which validates or verifies that we've got the right medication for the right indication with the right dose, and we're going to give it the right way. And then the provider administers the medication. It's a simpler process. It doesn't have as many checks and balances as in the hospital. I think ideally, another part of our process eventually should be our tablets scan the barcode that's on our medication and verifies that we have the right medication for the patient. I know that there's at least one vendor out there that's got an application or an app available for our tablets that does it. We're going to look at it, but I think it's going to be pricey. But I'm just contrasting what we do in the field versus what's done at the hospital. I think as EMS providers, we need to work toward a couple more cross checks so that we can be almost as safe as in the hospital. So what is our approach to avoid medication errors? Well, culture of safety is important. I think our chiefs endorse it. For me, everyone is responsible for safety of our partners, of the public, and our patients. If something's not right, you speak up. And I've had that conversation with providers in the past where we have medication errors. If you think somebody is making a mistake or something is not right, speak up and verify that they've got the right medication, they're doing the right thing for the patient. We do support blameless reporting of errors so that we can investigate the process. Again, from my perspective, medication errors are training issues. We just keep rolling back to, did you do your cross-check or not? For many of these errors, the cross-check procedure was bypassed or abbreviated. The other thing is part of our culture of safety, and we've had these conversations with some of our providers with the recent uptick in errors, is, slow down. High stress situations are dangerous for us and for the patients. Slow down, call for backup if you need it, get some extra hands. If it's very stressful and you have other responders show up, think about handing that patient over to another provider while you collect your thoughts. One of our errors recently was a very stressful situation. It was a chaotic scene. It was very gross in terms of what the patient did to themselves. The providers were experienced providers. They did a cross-check on the medication they wanted to administer, but because the situation had to put the medication down, they ended up going back to get medication, but they grabbed the wrong vial, administered the wrong medication. High stress situation. They had help on the way or almost there. They could have waited till help arrived and gained more control over the situation. Another thing for our approach is flagging high-risk medications. And high-risk medications are, for me, the paralytics, which is rocuronium. It's a high-risk medication. We need to make sure that it's appropriately labeled, maybe even partitioned or segregated from the rest of the medication so there's minimal, if any, risk of grabbing the wrong vial. And the other high-risk medications are different concentrations, midazolam or ketamine, and studies have shown in EMS when we have multiple concentrations, it increases our risk of error by 10 times. So if we want to reduce the risk, we could take some of the concentrations away. I think that's an error because we need both concentrations to safely manage our patients. Another thing to use is consider using either ResponseSoft app to do your med calculations or to look up our procedures, or if your agency subscribes to the HandHeavy application, use it. But use the applications we have available on our tablets to verify the medications, verify the doses, and to do the medication verification. ResponseSoft will calculate medication doses, including the volume to be administered if you put the patient's weight into the application when it's open. So you can use it, get used to using it if you're not using it now. And then our medication cross-check procedure, which is probably the last thing I'm going to talk about. And it's been shown to reduce errors. Here I say 50%, but it's between 50% and 2/3 based on the studies that have come out of Kansas where the cross-check procedure was started. So talking about that, this is right out of the protocol. On the left-hand side, you've got provider one who's going to provide the medication, and the provider number two who's going to verify. So provider one is going to start the conversation, so calling for a medication cross-check. Provider two will say ready. The provider one will say, I'm going to give this medication at this dose for this problem at this rate. And the second provider will agree and will ask, is there any reason not to? or any contraindications. Principal concentration for me would be allergies. Provider one would say no contraindications. Um, there's concurrence, and the second provider will say, okay, what volume are we going to give, or what quantity if you're going to give the medication orally. You're going to say, I've got, let's say, ketamine 50 milligrams per ml. I have a total of 2 milliliters here, and I'm going to give it IV slow push. The second provider will sound good. Go ahead and give it. So it will slow things down to do this correctly. It's maybe, once you start pulling the medication out, maybe it adds 15 to 20 seconds to the conversation, but it slows the conversation down. It verifies you've got the right medication, and it'll keep you and the patient safe. I also talked about contraindication. Also, another contraindication is expiration date. I think if you're doing your medication checks on a regular basis, the expiration date shouldn't be an issue. Some red flags really have to do with loss of situational awareness. Really, red flags are related to rushing, high stress, just overwhelmed by the situation, frequent interruptions, and preoccupation or confusion with other things. This is a circumstance where you step back, slow down, ask for help, stop and verify that you're doing the right things. And then review the situation out loud, talk about what you're doing, assess what's going on, make recommendations, look it up if you have to, look it up in the protocol, call the medical director, call me. Be the voice of the patient. I like this line at the bottom: slow is smooth, smooth is fast. In other words, if you slow it down a little bit, less errors to make, less opportunity to make mistakes, you're more likely to finish the task. And actually, that may be faster than making a mistake and having to go back and start over again. And it's definitely faster than making a mistake and having to write up an incident report. So please think about this. Talk with your crew members. Talk about it over lunch or at the lunch table while you're eating lunch, and talk it out. See how you're going to help each other with this process. The fictional case again, and really, I going back to this. All of these are possibilities. It could be that the patient got the correct medication via the correct route for the correct reason, and they were just more sensitive to the medication. Maybe they have a behavioral emergency and they're intoxicated, and the alcohol fed into it. And we know that alcohol makes excessive sedation and apnea more likely with ketamine. But it's also possible that the patient didn't weigh 100 kilograms. He was actually 75. If you look at the Elijah McClain case in Colorado, they thought the patient weighed twice as much as he actually weighed, but he was all bundled up in a hoodie and other stuff, so they overestimated his weight. Perhaps it was an incorrect dosing calculation. Didn't follow the cross-check procedure. They made an error in calculating the dose. Or perhaps they grabbed the highly concentrated version of ketamine instead of the lesser concentration, and they essentially double dosed the amount of ketamine the patient received. So instead of getting 200 milligrams, they got 400 milligrams. And perhaps they grabbed the wrong medication. Perhaps they just grabbed the rocuronium, drew it up, didn't do a cross-check. They had nothing to prompt them to think that it could be rocuronium because it was just mixed in with all the other vials in the medication bag. So all these are possibilities of why things went south with this patient. So again, throwing out my favorite drugs. I do have to point out one of our medications error was a confusion over fentanyl versus ketamine. And for me, fentanyl is hard to confuse because it's so hard to get into the way it's wrapped. But errors can be made, high stress situation, multiple distractions. Slow it down, get help, ask your partner to verify every step of what you're doing to get that medication safely administered to the patient. One question I'm frequently asked about was what happens if you have a two-person truck, you're transporting one patient, or the driver is driving, the provider in the back is with the patient, something goes wrong, what do you do? Well, my response is ask the driver to pull over, come back and help. If you need to, ask for backup, ask for a rendezvous with another agency. We have done that in the past. But you have to keep the patient safe, which means you have to have more than one person pulling medications and administering medications. If you think you might have to administer some Zofran during transport, or you want to administer during transport, but you want to start moving, do the cross check with your partner before the truck starts moving. So think about that. If you're two providers, one in the back, one in the front, patient's getting in trouble, you need to do something en route. Think about pull over, have your partner come back and help. So in summary, medication errors are never events. We should never accept them as something that just happened, or it happened because of the nature of our practice. Really, medication errors are more common than most of us would suspect. Many of them are related to underdosing the patient. When you look at fentanyl, is the third or fourth most commonly administered medication. A lot of us tend to go a little light on the dose. Not saying that's wrong, but that some may consider that an error. We need to support our culture of safety. It needs to be blameless reporting of adverse events so we can investigate. We have to have heightened focus on, when using our high-risk medications. A dose of IV Zofran is a whole lot different than a dose of IV ketamine or IV midazolam. You get used to using either the ResponSoft app or HandTevi in medication calculations and in verifying you're using the correct medication at the correct dose. Use the medication cross-check procedure. It's expected. It's a standard of practice. We have to verify that we are using the right medication for the right reason for the right patient. And then we all recognize that many of our patient care events are high-risk situations. Slow down, ask for help. Think about handing the patient off to another provider if you're at your limits. If we have in a tough situation, if it takes an extra 15 seconds to do it right, everybody is better off. None of our patients are going to die in 15, 30, 45 seconds if we don't get the medication in them quicker. So we have a little bit of time, slow down, do it right, and keep everybody safe. So that's all I have. Welcome to send in any questions or comments to me. This MEC Minute is going to be posted on EMS1 Academy. I anticipate the March MEC Minute is going to be posted on Vector. More to come on that. So again, thank you very much.